Hello and welcome to Clinical Society meeting. Today in the Clinical Society meeting, the first presentation is from Department of Neurology, which will be moderated by Professor Deepika Joshi ma'am and Professor V.N. Mishra sir. And the second presentation is from Department of Psychiatry, which will be moderated by Professor Srivastava ma'am. So I request the moderator for the first presentation to initiate it. Over to moderators.
Good morning to all of you. We are presenting an interesting case with unsteady neck and hand. So let's see the case and then we'll discuss. Dr. Deepika Joshi and myself, we are here to moderate.
Good morning, respected teachers. Myself, Dr. Kumar Bismay. I am going to present a rare case of young man with an unsteady neck and hand. A 22-year-old male from Ghazipur came to our movement disorder OPD with chief complaint of involuntary movements involving both upper limbs and neck for past 15 years. To start with, it developed as intermittent, sudden, brief, jerky movements involving the proximal and distal upper limb and also the neck. It was started initially in the right upper limb. After a period of 6 months to 1 year, it developed in the left upper limb. The onset was insidious in onset. Course was almost static for last 10 to 12 years. It was spontaneously present, though it was present in a resting position, but it was most predominantly seen in whenever the patient was doing an activity like holding any pen, holding any cup, and it was irregularly jerky movement were noticed. And these were not triggered by any touch or loud noise, and they were absolutely absent during sleep. It was also associated with posturing of both upper limb and left side of the face. It was also insidious in onset, non-progressive, only occurring during any activity. Whenever the patient was holding any object, drinking with a cup of water and writing, there was no diurnal variation. It was present almost throughout the day irregularly. And it was decreased by alcohol and it was absent at sleep. There was no history of any memory impairment, no neuropsychiatric manifestation, no history of any seizure, head injury, drug or toxin exposure. There is no other systemic complaints. Speech, hearing, and vision were also normal. There was no history of any febrile encephalopathy in his childhood. He delivered after a normal vaginal delivery. There was no history of any birth asphyxia or developmental milestones were normal, and he was adequately immunized. He was born out of non-consanguineous marriage, and no similar complaint was seen in any of his family member. And this is the patient. This is our patient. And summarizing our case, a young man with normal birth and developmental history presented with insidious onset multifocal, it is upper limb and neck, axon predominant, non-progressive myoclonus with mild limb dystonia without any cognitive decline, neuropsychiatric manifestation, seizure, trauma, or any family history. Before further going, let us discuss the recent classification of dystonia. The recent classification of dystonia, recently published in 2021, there are two, basically it has been divided into two axes. Axis 1 is the clinical characteristic and axis 2 is the etiological classification. In axis 1, we have to divide the patient according to the age of onset, like infancy less than 2 year, childhood onset 3 to 12 year, adolescent 13 to 20 year, early adulthood 21 to 40 year, and late adulthood more than 40 years. We also have to distribute according to classify according to body distribution. Like focal, it involves only one segment of the body. For example, writer's cramp. Segmental, when two contiguous body segments are affected, like blepharospasm and oromandibular dystonia, same segments, contiguous part. Multifocal means two or more non-contiguous sites like limb dystonia and cervical dystonia. And generalized dystonia means patient should have truncal dystonia with at least two other type of dystonia. Hemidystonia means it is limited to one side of the body. And we also have to look into the temporal pattern, the course of the disease, whether it is static or progressive. And we have to also see for the variability, whether it is persistent, same dystonic posture is present throughout the day, or paroxysmal, means whenever there is an external trigger is there, then only this dystonia is evident. After that, it is vanished. That means paroxysmal. Diurnal. To say the dopa-responsive dystonia, they have a specific circadian rhythm. In the morning, when the child gets up, there is no dystonia. But by the time of evening and night, there is significant posturing is there. That is called diurnal variation. Action specific. Whenever the patient does some specific kind of action, like writing, then only this dystonia will be visible. Otherwise, it is absent. Other associated features like whether it is an isolated dystonia, combined dystonia, or complex dystonia. Isolated dystonia means only dystonia with tremor. No other movement disorders are present here. Combined dystonia means dystonia plus any other movement disorder like dystonia plus myoclonus, dystonia plus Parkinsonism, dystonia plus dyskinesia. Complex dystonia means dystonia with other neurological or non-neurological manifestation. For example, Wilson disease. Here the patient have, along with dystonia, patient have tremor, patient have neuropsychiatric manifestation, cognitive decline, cataract, patient may have hepatic involvement. So it is a multi-systemic involvement that is comes under complex dystonia. And the etiological classification say that according to the CNS pathology, whether there is an evidence of CNS degeneration or any structural lesion or without any structural or degenerative lesion. The inherited or acquired, it may be autosomal dominant, recessive, X-linked, mitochondrial, acquired condition like whether there is any history of perinatal birth injury, infection, obviously like SSPE, drugs like neuroleptics, toxins, vascular, neoplastic, brain injury, or functional or unknown like sporadic or any familial. So by looking all these factors in our patient, which came at around age of onset of around 7 to 8 years, multifocal in distribution, static course, dystonia and myoclonus without any family history. So axis 1, this is our clinical classification, which is dystonia plus myoclonus. So it comes under combined dystonia. Axis 2, we are not sure till now. So putting all this together, so we kept these things our differential diagnosis like genetic causes and metabolic causes. In genetic, actually, this patient with dystonia and myoclonus, it comes under an umbrella, and it is now the term is called dystonia myoclonus syndrome because at least more than 20 genetic mutation has been noticed, and all they present with dystonia and myoclonus, same phenotype. Some differences are there, but clinically differentiating it is very difficult. But if we see dystonia, sarcoglycan epsilon mutation, this is the most common type of dystonia associated with dystonia and myoclonus. Around 20 to 80% cases comes under this category. Predominantly here is the myoclonus is the predominant rather than the dystonia. Upper half of the body is present and the course is almost static. Another type of dystonia is the dystonia due to GTP cyclohydrolase 1, that is the dopa responsive dystonia. It is also a childhood onset dystonia, but the peculiar point is there have a diurnal variation. Patient comes with features of Parkinsonism, and it is a dopa responsive. It responds very good to levodopa. Another variant is dystonia GNL variant. This patient usually comes around third and fourth decade, and there is predominantly craniobulbar involvement of dystonia, like lingual oromandibular dystonia. ADCY5, and this is the potassium channel mutation, KCTD17. In these two mutations, they usually present with dystonia predominant rather than myoclonus predominant, and they have a craniobulbar predominant involvement. Another is calcium channel 1AB mutation. Along with dystonia and myoclonus, here patient comes with cardiac arrhythmia, painful muscle spasm, and other differential like metabolic causes like isolated vitamin E deficiency. Classically, vitamin E deficiency present as cerebral ataxia with peripheral neuropathy, but it can rarely also present with myoclonus and dystonia. Even SCA14 can also have rare, though it can present with dystonia and myoclonus. So on examination, the patient was conscious oriented. There was no facial dysmorphism was there. KF ring was absent. Cranial nerve examination was also normal. There was no opsoclonus. Opsoclonus means patient has it is a multi-directional, chaotic, disorganized movement because there is a syndrome called opsoclonus myoclonus. That is why we have seen there was no opsoclonus. Fundus was normal. There is no optic atrophy because some of the mitochondrial disorders can also have optic nerve involvement. Motor examination was normal, just other than this involuntary movement, which is I'm going to show in the next slide. There was no feature of any Parkinson. There was no rigidity, bradykinesia, or tremor, or postural instability. Sensory and cellular examination were normal. and other systemic examination were normal. You can see the brief jerky movement involving the right hand distally and proximally and part of the neck also. You can see he is holding the pen in the extended hand and he is writing with elbow extended, wrist is extension and slight abduction in the right shoulder joint. Actually, he was a right-handed person. Because of this jerky movement, he became left-handed. And you can see whenever he's trying to write, this jerky movement significantly interferes his writing. That is the classic called action tremor. Whenever the patient tries to do any action, then this action myoclonic. You can see whenever the patient is trying to write, then only this jerky movement is occurring. That is the typical case of action myoclonus. And you can also notice the manner he is holding the pen. There is excessive flexion at the left thumb interphalangeal joint, and there is hyperextension in the left index and middle finger. When asked to drink some water from a cup of tea, you can see because of this jerky movement, he can drink. And you can also see in the left side of the face, there is some sustained muscle contraction around his eye. When a patient asked to keep his hand in a posture, extended posture, you can see this distal brief jerky movements involving the fingers and his wrist. And there is some part of negative myoclonus also can be noticed here. Extraocular movements were normal. There is no history of any gaze restriction. Speech is normal. There is no finger nose test, finger nose sign, no dysdiadochokinesia. Here, initially patient fumbles, but later on he can normally do it. He was able to walk in a tandem gait. On standing position, you can see the brief jerky sudden movement involving the distal hand. So on further neuropsychological examination, his anxiety score was 11, depression score was 2, and there is OCD score was 9. There was mild symptoms. Basic investigation like CBC, LFT, renal function test were normal. Lactate and ammonia were normal. Sugar were normal. Thyroid profile were normal. Ultrasound didn't show any hepatosplenomegaly. ECG, 2D echocardiography were normal. EEG was normal. MRI brain was also normal. So this is the T1, T2 and flare sequence brain of the patient. And we can see around the basal ganglia, there is no hypointensities. And then further we send the patient for whole genome sequence, and we can see that the sarcoglycan epsilon gene mutation was noted, which is suggestive of myoclonic dystonia because this, which is an autosomal dominant and it is an pathogenic. We can also see that there is no other mutation other than this SGC mutation was noted, and to note that this site of mutation, that is the 7q mutation, is specific for this SGC mutation, but the type of mutation, the variant which we have found here, has not been previously reported. So we believe that this is a case of novel mutation. So by reviewing our classes, the axis 1 classification is the combined dystonia, and the axis 2 the inherited dystonia, that is autosomal dominant dystonia. So our final diagnosis was dystonia myoclonosporadic as mutation because both parents were also tested and they came out to be negative. By the time patient came to us, he was already on valproate, clonazepam, levetiracetam, and propranolol, but there was no response. We added zonisamide recently. Now coming to discussion, there is a beautiful article published by Menozzi et al. In Movement Disorder. When a patient comes with myoclonus and dystonia, we have to see which part of the body is affected, whether the neck or upper limb, or there is axial involvement, or with generalized involvement. So in our patient, is the neck and upper limb is affected. So second thing, we have to see the onset. The onset is either it is less than 20 year or not. In our patient, it was around 7 to 8 year. So after less than 20 years, is there any psychiatric manifestation? If any psychiatric features like OCD, depression, anxiety, alcohol dependence, so if any of these features are present, then patients should be screened for SGCE mutation, because this is the most common mutation. And if it is negative, patient may come with DYT15, because this also presents with similar phenotype, but this is a mutation due to chromosome number 18, but the exact mutation till now has not been identified. But if it is also negative, then we can see for other clinical features, like if it is presence of tremor in upper limb and head, anoctamin 3, developmental delay, intellectual disability, epilepsy, this tubulin beta 2B gene mutation, KCTD mutation, there is a dystonia predominant with craniobulbar and speech involvement, cardiac arrhythmia and painful cramps, calcium channel mutation, sensory ataxia can present with alpha tocopherol A mutation. And if the patient comes after 20 years, around third year, fourth decade, then we have to see for additional feature. Is there any psychiatric feature or enhanced startle response? Then should be Rallin mutation. Laryngeal involvement, tremor, it is GNL mutation. If patient comes with axial predominant myoclonus and dystonia, if cerebellar features is present, SCF14 should be considered. And patient with generalized dystonia, we have to see for levodopa response, because if levodopa response is there, then it is a dopa responsive dystonia. It can be due to GTP cyclohydrolase 1 or tyrosine hydrogenase mutation. Or is there any no levodopa response? Then see for other dysmorphic feature like short stature, triangular face, that is a maternal uniparental disomy 7 mutation, abnormal eye movement, nocturnal exacerbation, neuropsychiatric behavior, cognitive decline, ADCY5 mutation, chorea predominant. And this is the thyroid transcription factor mutation. We can also see for chorea, thyroid, and respiratory involvement. So now coming to the diagnostic criteria for myoclonus dystonia, the major, minor, and exclusion criteria. The major criteria says that there should be myoclonus either isolated or predominant myoclonus, not predominantly dystonia. Motor feature involving the upper half of the body. There should not be any truncal dystonia. Positive family history, onset should be before 18 years. Minor criteria include OCD, alcohol dependence, spontaneous remission of limb dystonia during childhood and adolescence. Literature says that up to 5% patient of dystonia and 22% of myoclonus, they spontaneously recover. Response to alcohol. And there are other exclusion criteria. We have to rule out other neurological disorder, abnormal MRI, and other findings. To say definitely it is a case of myoclonus dystonia, there should be 5 major criteria or 4 major plus 2 minor criteria. This actually fulfills our patient, because our patient doesn't have any family history. So 4 major plus 2 minor criteria. For probable 4 major or 3 major plus 2 minor criteria. So this is an article from India. Actually, this is a very rare disorder. Only 1 to 2 cases per 10 lakh patient has been, it is the prevalence. In India, 5 patients has been reported from 3 different families. This is by Puneet Jain et al. From Lady Hardinge Medical College. You can see 3 patients from family 1 and 1 from each family 2. The age of presentation is 12, 9, 45, 5 and 4. And all the patients presented with myoclonus, all the patients presented with dystonia. All the patients have axon myoclonus. And you can see the age of onset is 2 year, 3 year. Only 1 patient came at around 32 year, and rest of the patient was 3.5 and 3 years. So it is an early onset, around less than, most of the patient comes within 10 years. Very few comes with 10 to 20 years. Part involved is the lower limb can be involved. Around 25% cases, lower limb can be involved. And you can see predominantly upper limb involvement. The part affects the hands, cervical, hand. Response to clonazepam is poor in 2 cases, and SGCE gene mutation was present in 4 out of the 5 cases. So we have already presented this case in the national level in the Movement Disorder Society of India. Thank you.
Thank you, Dr. Bismay. So before moving to the questions from the chat, I have some doubts. Like in the investigation slides which you are showing, just show it again.
Sir.
Yes, the investigation one. Yeah. Just tell me what were the things in your mind when you asked for these investigations.
Sir, as because when we are doing these cases, this normal level of ammonia lactate level, we try to rule out any hepatic involvement because there are number of conditions which can hepatic involvement can be there. Sugar and thyroid profile we ruled out because in thyroid there are cases where this
But
TTF.
if you go with the history of this patient, there is no point in ordering the serum ammonia value and serum lactate value.
No, sir. So because the mitochondrial disorder is one of a possibility, that is why we have sent the serum lactate level actually, sir.
Okay.
And we have ruled out ultrasound just to rule out in hepatosplenomegaly because storage disorder also comes in a differential diagnosis, but in this patient doesn't, this clinical picture doesn't fit to storage disorder because there is static course, no neurocognitive decline, no other systemic manifestation. So just to rule out, we just did ultrasound, and there are some calcium channel mutation which can also present with some arrhythmia. That is why we have ruled out ECG. EEG just we have to try to rule out whether there is any cortical involvement is there or not. MRI brain was also normal. It's just a part of the routine investigation, sir.
Okay. Because ultrasound abdomen hepatosplenomegaly you can detect clinically also, like in the examination. So if it is not there,
Yes, sir.
I think okay. Alcohol responsive. Whether patient was earlier taking alcohol or he was not taking alcohol.
Yes, yes, sir. Patient was taking alcohol because patient knew that after taking alcohol his symptoms used to subside, and patient if there is an exam, patient take alcohol and then go to exam because he knows that his symptom used to subside after taking alcohol, sir.
Okay, like in the minor criteria, it is there that it is alcohol responsive or not. So if somebody is not taking alcohol, will we try the alcohol as an agent to check that it is responsive or not?
No, sir. Actually, this is not a recommendation, but it has been pathophysiologically it has been seen that because it is the hyperkinetic movement disorder if you are taking alcohol, because alcohol increases the GABAergic transmission. So rather that is the reason these hyperkinetic movements are decreased. That is the only hypothesis given, but the exact pathophysiology has been not known, sir.
Okay. So I request the moderators, please, if you want to add something, then you can add. Otherwise, we will straight go to the questions.
Good morning, everybody. I think it has been presented very systematically by Dr. Bismay. Just to say that if any case of movement disorder comes, if we approach the case systematically, because now they are well validated criteria and classification, like we proceeded. If we first do the axis 1, so we can zero down on which disorders we want to see. Otherwise, unnecessarily we'll be sending the patient for genetic testing, and irrelevant investigations can be avoided. So if we approach systematically and first make the axis 1 diagnosis, and then we come to the axis 2, so we are able to arrive at a diagnosis much easily and in a more systematic manner. And rest of the things he's already discussed, because the age of onset, the distribution, the relatively stable course of the disease, the sparing of the other cerebellar, apart from the dystonia myoclonus, the other neurological axis was spared, and there was no other systemic involvement. So this case is it's a rare case, but it's a prototype of a dystonia myoclonus syndrome, and the course is usually benign, or I would say relatively stable. We have started the patient on zonisamide. There is recently a randomized trial in which they have shown improvement, and the patient has some improvement. He is yet to come on the follow-up, so telephonically we inquired, and there is some improvement in after starting zonisamide in a dose of 200 mg. He is currently taking. Thank you.
Thank you, ma'am. So I request Professor Ashok Chaudhary, sir. Sir, please unmute yourself and ask your question.
Good morning. Very interesting case of movement disorder. In the differential diagnosis, did you consider Wilson disease as one of the possibilities? Because there was movement disorder and there was no other precipitating factor for it. So, I mean, one of the possibilities should be Wilson disease. And exome sequencing takes 4 weeks time to have the results. So what were your possibilities initially when the patient came to you? And did you do serum copper levels or urinary copper levels? Because as I understand, above the age of 5 years, any new onset neurological symptoms not explained otherwise, I'm not talking of genetic mutations, genetic variants, one should always exclude Wilson disease. So that's my, the query. And was there any history of neonatal jaundice? Sometimes neonatal hyperbilirubinemia, there could be basal ganglia damage. Of course, there may be other manifestations, but sometimes it can go unrecognized. And later on childhood or early or young adult, the person could have movement disorders or the kind of thing. So these are my queries. Thank you very much.
Actually, this patient presented had the onset of symptoms at 7 years of age. He came to us when he was 22, so almost a 15 years gap, first of all. Secondly, for Wilson's, untreated Wilson's to remain so well, like no cognitive involvement, and the characteristic dystonia, Wilson's disease is a symptomatic dystonia. So it usually starts from the craniobulbar region with drooling of saliva. Like if it had been Wilson's, lot of things would have happened till now, untreated Wilson's for 15 years. So we just went with a KF ring, but Wilson's we did not consider. Even we went, and when the MRI was normal, so it's impossible for Wilson's to survive 15 years with a normal MRI, no involvement of brain, and the negative KF ring. And his birth history was essentially normal. There was no history of any perinatal insult or no history of any neonatal jaundice in this patient.
Okay. I request Dr. Upender Kaur. Dr. Upender, you can unmute and ask your question.
So am I audible?
Yes, you are audible.
Okay, so my question is to Dr. Bismay. See, you have mentioned that the patient was on multiple neurologicals. I think he was on levetiracetam, clonazepam, propranolol, and the fourth I missed maybe valproate. So he was not responding to these. But then why these drugs were continued if there was no response?
Yes, ma'am. These drugs were prescribed from outside. We just added one more drug, jonisamide, and we have also given a patient another option of DBS, because if the patient is not responding, there is one option is called DBS. Even DBS.
No, you are not getting my question. My question is, if the patient is not responding to multiple neurologicals, you can add other, but what is the point of continuing the previous neurologicals if there is no response to that?
No, we stopped.
Yes, ma'am. We have stopped the drugs and we have added jonisamide.
But in
You stopped all of them.
But in your presentation, you mentioned that you continue with that medication.
Yes. In your presentation, it was mentioned that the other drug was added. All other previous drugs were continued.
He's only on zonisamide monotherapy because actually he has this patient has come from all the institutes, right from Mumbai to Delhi. He has gone everywhere. So, and he's a veterinary student, so he's very well aware. He knows he responds to which treatment or not. So presently he's only on zonisamide 200 mg per day, and through the telephonic this thing he has had some improvement, and we have given him the option of DBS also. He's not, I think probably that would have been an error. He's not on the other anti-epileptics.
Okay.
Okay, ma'am. Thank you. I request Dr. S.S. Chakravarti, you can unmute and ask your question. Dr. Shank, you can unmute yourself. Okay, there is one. Okay. Dr. Shank, try once again. Now you can unmute yourself.
Okay, yes. I had a brief question actually. I think this patient was 20 years old So I was curious when he started consuming alcohol to see whether there is response of his movement disorder. And someone must have suggested it to him, or he just took it up quite early, maybe in student life.
So the patient was actually a veterinary student. He was studying in Mumbai. Only in Mumbai, when he took alcohol, then only he saw that in the next day his symptoms has been significantly reduced. That is the reason patient is saying, but no one has asked him and recommended him to take alcohol. Patient self, he noticed that after taking alcohol, his motor symptoms are subsiding. Sir.
Okay, thank you, thank you.
Thank you.
Actually, his freshers party, so he was encouraged by the seniors, probably that is what he told. So he took a little amount and he was very surprised that the movements had significantly subsided. But he doesn't take it because now his course is relatively stable. He's handling his life he's not much disabled.
Okay, ma'am, thank you.
Thank you. I request Professor Rani Singh. I think you have put some question. You can unmute yourself and ask your question. And that will be a last question.
Yes, I have a question directly not related to this problem. Is there this choroid cyst in the right ventricle in the developing fetus is a very common and self-resolving as the ultrasoundologist suggests to the patient?
Ma'am, I think the question should be pertinent to this presentation. That can be discussed later on. Thank you.
Okay.
So thank you once again, Professor Deepika Joshi ma'am and Professor V.N. Mishra sir for moderating this clinical society meeting first session. Now moving to the second presentation, it's from Department of Psychiatry, and I request Professor Mona Srivastava ma'am to initiate it. She is the moderator for this presentation.
Good morning to all. From the Department of Psychiatry, I'll ask Dr. Harsha Singh, JR2, to start her presentation.
A very good morning to respected faculty members. I am Dr. Harsha Singh from Department of Psychiatry, and today I'll be presenting a case titled Take out your mask. And today I'll be presenting a case titled A Puzzling Case of Movement Disorder. Socio-demographic data. We are presenting the case of Ms. B, aged 17 years. She is studying in class 12, belonging to low socio-economic status, Hindu by religion, resident of Jaunpur, and she was accompanied by her father. Total duration of illness was 3 years, which was insidious in onset. Course was continuous. There was no predisposing, precipitating, or perpetuating factor. She presented to us with the chief complaints of headache since 3 years, involuntary movement of both external ear pinna since 1 year. History of present illness. The patient was brought to Psychiatry OPD, IMSBHU, with the complaints of headache since 3 years that was bilateral, diffuse, mild to moderate in intensity, and band type. Present for 4 to 5 days in a week, associated with pain in the temporofacial area with no radiation. The pain was aggravated by studying and stressful life situations. It was not aggravated by exposure to sunlight. The pain used to be relieved on rest. It was not associated with nausea, vomiting, photophobia, or phonophobia. The pain was not associated with any movements like chewing, change of posture, or exertion. Neither it was associated with dental or eye complaints. There was no association with any autonomic features also. Along with headache, she also had semi-rhythmic, involuntary, synchronous elevation and retraction of both external ears, which was of equal amplitude and frequency, around 50 to 60 per minute since 1 year. The involvement of the ears was equal on both sides. It was episodic, lasted up to 2 minutes. The episodes used to occur 4 to 5 times a day, were absent during sleep. Movements of the neck muscles, limb, facial twitching or slurring of speech. Decrease marginally on distraction or on doing cognitive tasks like mathematical calculations. The movements were sometimes associated with pain in and around the muscles involved. The movements were not associated with posturing, clenching, and tongue bite. There was no palatal tremor or other abnormal movements in the body. The patient had no discomfort or urge preceding the movement, not associated with loss of or clouding of consciousness, not associated with any tingling sensation anywhere in the face. This is a video showing movement in one of her ears. We can see how her ear is moving. This is another video showing movement in opposite ear. We can clearly see how her ear is moving. Past history. There was no physical or psychiatric illness in the past or any history of drug exposure, no history of childhood sexual abuse, no history of COVID infection. Personal history. She started schooling at the age of 5. She had average academic performance throughout. There was no history of any disciplinary complaint in the past, no history of any substance abuse reported. Menstrual history. Attained menarche at 13 years, cycles were regular. Medical and surgical history. No history of any medical or surgical illness in the patient. Both COVID vaccines, that is Covishield, were received as per schedule. Treatment history. She had consulted multiple physicians, psychiatrists, and neurologists. She had been put on multiple drugs like anxiolytics, antidepressants, anti-epileptics, but has shown no response to any treatment. Distraction technique and relaxation have shown mild to moderate response. Birth in early development, a term normal home delivery, cried immediately after birth. All the developmental milestones were within normal limit. There was no history of any illness, hospitalization in her early life. Vaccination history was as per schedule. This slide shows a family history. There were a total of 5 members in the family. There was no history of any psychiatric or physical illness in family. No history of COVID-19 infection in family. General physical examination. Vitals were stable. There was no pallor, icterus, clubbing, cyanosis, pedal edema, or lymphadenopathy. Central nervous system examination. Her high mental functions. She was conscious, alert, and comprehension was normal. Tone was normal in all the limbs. Motor function. Power was 5 by 5 in all 4 limbs, and all DTRs were within normal limit. Plantar reflex was bilaterally flexor response. Spine inspection revealed no abnormality, no signs of meningeal irritation, involuntary movement present, episodic semi-rhythmic elevation and retraction movement of both external ears, lasting for 1 to 2 minutes at a frequency of 50 to 60 per minute approximately. Her systemic examination was within normal limit. Mental status examination revealed a kempt cooperative young girl who was sitting comfortably. She was answering the questions asked, upset and anxious by the problem she faced. Affect was objectively anxious. She was oriented to time, place, and person. Intact intellectual ability, personal judgment was intact. Insight for psychiatric problem was present. So we are keeping a provisional diagnosis of chronic tension type headache with focal dyskinesia, moving ear syndrome. The points in favor of our diagnosis are persistent headache occurring on most days, band type, bilateral, and present throughout the day. semi-rhythmic, slow, episodic, focal movements of the ears, lasting for only a few seconds to minutes, spontaneous movement not under voluntary control. The points against our diagnosis are no response to any medication, no exposure to neuroleptics. This video clearly shows the movements in one of her ears. Now we will see that after I give her a cognitive task, I told her to do a serial subtraction test, her movement will reduce. We can see the movement. At this point, we can see how her movement is decreasing now, and it has now stopped almost. This is another video showing movement. We can see clearly how her ear is moving. I gave her another cognitive task of doing certain sums on a piece of paper. We can see her movement is decreasing now. And we can see how it has stopped completely. The ear is not moving at all at this time. We'll also see that after I ask her to stop doing the calculations, her movements will shortly resume. We can see clearly how the movements have resumed now, after I stop her from doing the cognitive task. Differential diagnosis. We are keeping our first differential as functional movement disorder. Points against the diagnosis are no clear association with any stressful event, absence of labella indifference, absence of any primary or secondary gain. Movement disorder stereotypy. Point against unusual area of involvement, not associated with intellectual disability and autistic features or chronic psychosis. The third differential is movement disorder tics. Points against no history of any habit movement, neither associated with any urge nor tension relieving properties, nor was it being suppressed voluntarily. The fourth differential is epilepsia partialis continua. Points against the diagnosis are that her EEG was normal, no response to anti-epileptics was there, and an uncommon site of presentation.
Just to point out also the points favoring also. Points against you are mentioning, points favoring that diagnosis. In the differential diagnosis, move to that slide. Yeah.
Yes, sir.
What were the points favoring this functional movement disorders?
So the points favoring functional movement disorder was that it was so there was some sort of stress in her life also. No clear stressful event was associated, but some stress was ongoing. Then secondly, it used to decrease on distraction. Then that is why we kept the diagnosis of functional movement disorder. Then also the interference that it was causing substantial interference in her personal and social life. So we kept the first differential as functional movement disorder. Movement disorder stereotypy, because as we know that stereotypies are purposeless, rhythmic, repetitive, movements. So that is why we kept the differential as stereotypy. But the problem is that stereotypies are mostly common in the areas of hands. So unusual area of involvement was there, rarely seen in the area of ear. So that went against the diagnosis. Movement disorder tics. Tics are again, they are rapid, brief, repetitive movements. So we kept the differential as tics. But then again, in our patient, there wasn't any premonitory urge, nor was there any relief of anxiety after doing the movement. And in tics, we know that the movements can be suppressed voluntarily also. for a certain period of time, but that wasn't the scenario in our case. Epilepsia partialis continua we kept as a differential because it is a focal epilepsy that usually occurs for very short duration, that is for seconds to minutes, and it also involves it mostly involves the areas of face and hands. So we kept it as a differential. These are the routine investigations. We can see that most of all her routine investigations were within normal limit. These are her specific investigations. Her CT brain revealed no abnormality. The MRI brain also revealed no abnormality. Her video EEG was normal. The EMG was done outside and it revealed bursts of activity in the auricularis muscles. These are the films of MRI and CT that were within normal limit. This slide shows the picture of EEG. Her video EEG was also normal. This is the photo of her report. The psychological tests that we applied were HAM-D, that is Hamilton Rating Scale for Depression. The score was 5 and it did not reveal any depression. HAM-A revealed a score of 10 and it revealed mild anxiety. Dissociative experience scale score was 20%, which is considered to be normal. The treatment given to her from our side was tablet amitriptyline, 25 milligrams 1 HS, tablet clonazepam, 0.5 milligram, half tablet BD, tablet tetrabenazine, started with 12.5 milligram OD and currently she's on 12.5 milligrams 1 BD. Thereafter, she was referred to Department of Neurology, where she has been posted for receiving injection botulinum.
You mentioned in your presentation that the patient was on taken multiple drugs earlier, anxiolytics, antidepressants. So you have not mentioned what drugs patient has taken. So whether amitriptyline was not started initially, like before coming to at your place, a patient already taken amitriptyline, clonazepam?
Yes, sir. Actually, we only got some of her prescriptions. Majority of them were missing, and she was very irregular with the treatments. Initially, amitriptyline wasn't right. She was given SSRI probably for the headache and her depressive complaints, and she was tried on multiple anti-epileptics also. The prescription which we got, she was tried on sodium valproate and carbamazepine, and in SSRI she was taking paroxetine.
Okay.
Non-pharmacotherapy, she was taught about distraction technique and deep breathing and relaxation exercises. Discussion. Segmental dyskinesia of the cranial and upper limb muscle is well recognized. Restricted and isolated dyskinetic movements of cranial musculature, such as muscles of the pinna, are extremely uncommon. There are a few case reports of moving ear syndrome. An article by K. Ray Chaudhary et al. In 1996 illustrated the phenomena of moving ears as a manifestation of focal dyskinesia. It mentioned about a 23-year-old man with involuntary movement of both ears and adjoining scalp. It also mentioned about a 32-year-old man with similar complaints. The MRI findings and CT scan for both patients were normal. Patient 1 obtained considerable benefit from oral clonazepam, whereas patient 2 responded well to botulinum toxin type A, 40 units. Another case report by L. Carlier et al. Described dyskinesia in a 57-year-old woman who complained of involuntary movement of both ears for a year. The movements used to disappear during sleep, like in our patient, and there was no history of local trauma or neuroleptic treatment. Her investigations were normal and she responded well to local injections of botulinum. The clinical appearance of our patient's movement disorder closely resembles dyskinesia because it consists of stereotyped focal movements affecting the ears, which were slow, rhythmic, not suppressed by voluntary muscle contraction, and lasting for few minutes. Focal dyskinesia can affect various regions of the body: ear, back, shoulder girdle, upper extremity, and abdomen. Also, the presentation with the focal non-progressive movement disorder in adulthood is suggestive of the same. There are case reports of dyskinesia developing after SSRI exposure which could be an explanation in our case also. The present pandemic and also the vaccine have been reported to precipitate certain movement disorders, which are grouped under a broad category of FMD, that is functional movement disorder. However, this factor is not associated with the symptoms of index patient. The reasons for presentation are it was a rare disorder, diagnostic considerations, and management issues. With this, I end my case. Thank you.
Thank you. I request Professor Mona Srivastava ma'am. Sir, ma'am, if you want to add something, you can add. Then we will start taking questions from the chat.
Dr. Harsha has aptly summed up the case and the presentation. There's nothing specific that I would like to add, only that there is a recent article in 2021 which has given a lot of focus on functional movement disorder, and varied case reports have come after the COVID-19 infection. Because of the infection per se, and also because of the associated factors like quarantine, and social distancing and staying at home, etc., they have all precipitated this kind of a stress, and multiple movement disorders have come to fore. Before closing, I would request Professor Deepika Joshi ma'am to give her expert comments, and in fact she has also come across a couple of cases like this, so it would be better that she also gives her expert comments.
Yeah, thank you, ma'am. Yeah, this was a very interesting case. In fact, we have 2 more such cases which we will be presenting in our society. And it's really a clear type of dystonia because there are few case reports described, and people have given botulinum toxin, and we have actually it will require around 80 to 100 units because bilateral we have to inject the posterior auricular muscles. So because affordability was an issue with this girl, so we have she's planned on our next, we do it free for certain patients, and we would really like to see her response first, the post response. And people have also gone ahead in a unilateral case. There is a single report of doing a deep brain stimulation because it's very disabling for the patient. They persistently, the girl is having these type of movements. So,
Ma'am, sorry to interrupt you here. What is the level of evidence of using botulism toxin in such type of patients?
no, there are only case reports are there. So it's this disorder itself is so rare, isolated cases that there would not be more than 10 cases as overall in the, yeah.
4 cases are there.
Yeah.
I think this will be the fifth
case, and 2 more of our cases. There is just in series, one series has described 1, another 3. So because we have to relieve the patient, no, ultimately she is not responding to drugs. So when we reviewed the literature and discussed, so then we came across this. So we have planned for botulinum toxin injections in our 2 patients and also in this patient, and then we'll see the response because it's new for us also, and not much literature is available.
Okay, thank you, ma'am. I request Professor Achyut Kumar Pandey, please unmute and ask your question.
Thank you, Dr. Abhishek. Am I audible?
Yes, sir, you're audible.
Thank you, Dr. Harsha, for your lucid presentation. And I want to share one, because this is these are the very puzzling movement disorders. I have seen one of the case which was diagnosed for schizophrenia and on antipsychotics by the multiple consultants for last 17 years, and she was presenting with this movement disorder, and then finally when the diagnosis was made, this was it was not schizophrenia, it was whole dissociative disorder, and this was because by the distraction technique only we could diagnose this. So I congratulate for diagnosis this puzzling movement disorder. The couple of questions are there. Why if this is the functional, your working diagnosis is functional, then why you are keeping this patient on tetrabenazine and still continuing? One, and what the efforts have been made to assess stress quantitatively and qualitatively, and what was the efforts made for stress management in this patient? Thank you.
Thank you for your question, sir. So the diagnosis, the working diagnosis that we are keeping is chronic tension type headache along with focal dyskinesia. So we are treating her on the lines of dyskinesia. That is why we are using For tension type headache, we are giving amitriptyline. For anxiety, clonazepam. And for considering dyskinesias, we are giving a tetrabenazine. So that is the answer to first question.
Stress management.
Dr. Abhishek, can I come in?
Yes, yes.
See, I have a few basic queries. First of all, you diagnose, the Department of Psychiatry diagnosed in this case as a functional movement disorder, and getting a good response with cognitive behavioral therapy, and then we saw that entrainment and distraction had a positive response. So if something is functional, how are we treating it with Botox? Because the cases that the slides have shown, they supposedly are not functional. They are focal dyskinesias of ear pinas and different movement disorders, and nowhere in their cases have they mentioned that it's supposedly a movement disorder, supposedly a functional disorder. And if something is functional, so cognitive behavioral therapy showing a good response, that is supposed to be the treatment of choice rather than giving the Botox, where you yourself telling that this is a functional movement disorders. And in the differentials, movement disorder stereotypy, roughly 30 to 35% of the patients have normal mental abilities, right? So that is not against that. I mean, 35 to 40% of the patients, they can have normal mentation. So my basic query is, and when you consider something a functional disorder, movement disorder, with a good response to cognitive behavioral therapy, how are Botox going to help? And if you're citing those 4 cases, 5 cases, none of the case has mentioned that it is supposedly a functional movement disorder, right? And that is the point. And there is a debate. Why do you continue tetrabenazine in functional movement disorders?
I think the point has been missed. We have come to a provisional diagnosis as chronic tension type headache along with focal dyskinesia. Our differential is, one of the differential is functional movement. So our working diagnosis is focal dyskinesia. And for precisely that point, we are giving her tetrabenazine, although she has not shown any response.
Ma'am, but why would the focal dyskinesia would respond to cognitive behavioral therapy, and the movement disorder would disappear on entrainment and distraction?
No, but dyskinesia are also known to suppress for a certain amount of time by distraction techniques. And nowhere have we mentioned we are trying cognitive behavior therapy for her anxiety, and it has not helped her in dyskinesia. Nowhere in the presentation has this come forth that cognitive behavior therapy has decreased her dyskinesia to only there is a relief in her tension type headache. And distraction is known to decrease dyskinesia for some time and to certain
Sorry,
extent.
ma'am, I disagree with your comments. Actually, the focal dyskinesia will increase after distraction. If it is organic dyskinesia, it will increase after distraction. And if it is functional, it will decrease after distraction. This is the clear-cut demarcation point between the functional dyskinesia and the organic dyskinesia.
Exactly.
No, but this is a very minimalistic view, and we will disagree because a lot of literature search we have done, and we have reviewed a lot of articles.
Ma'am, but you only showed 4 case reports where none of...
Oh, as I said, there is this particular article in 2021 which we again reviewed, and there was another article by on EMG FMD, with FMD's EMG recording in FMD by in the Movement Disorder Journal, which occurred again in 2019. This also specifically says that FMDs or dyskinesias are very, very overlapping condition. And there is no clear-cut demarcation that a simple distraction will be helpful in coming to 100% conclusive diagnosis.
Ma'am, but the case reports that you mentioned, none of the case reports did they mention that
any research starts with case reports, and since this is a rare disorder, we really cannot have a lot of evidence. But whatever case reports we have come across, we have referred the patient to the Department of Neurology, and that is what is tentatively planned, and we are yet to see the response to the treatment.
Okay,
and one thing must be there, that this patient is economic.
And thank you, Professor.
I would just like to emphasize one point. See, there is a lot of overlap, as Madam has said, and there is a paucity of literature on this matter. botulinum toxin was planned because to relieve her, because symptomatic benefit should be given to each and every patient. So after a written consent, it was explained, and we'll see. We are not saying we'll put her permanently on botulinum toxin. If she improves, we are just going to see it. We'll give it one time, and there are few cases reported, and she has been on lot of drugs throughout, lot of anti-epileptics, anticholinergics. She has received lot of drugs, and
So,
she is
ma'am, if
disabled.
Botox is found to be useful, if you suppose it to be useful, then why not continue tetrabenazine and increase the dose along with other
See,
antidystonic
after
drugs?
that, because she was. We'll see if it comes out to be. Then and I also have two cases. Then we'll report these cases. We have planned it already that we are going to write it up further. So we'll see the response. We are not saying it is 100%, but with entrainment and distractibility, lot of organic disorders may also subside to certain extent. So that is not 100% foolproof that because it is distracting, it cannot be organic or vice versa.
And
Yes.
what
So we'll
percent of it of the organic diseases do respond to the entrainment and distractions?
Dr.
About a
Pathak,
quarter of patients have been seen in various
sorry
types
to
of
interrupt you here.
tremors and
Let me stop here.
30 to 35% is the figure which is quoted in
yes,
the literature.
that
Uh, I am stopping you here because I think the time is limited. The debate can be continued in other channels also. And points well taken. I think this is in the medical science, nothing is 100%. So you can't be sure. And differential diagnosis can be challenged, and treatment can be challenged, and debate can continue. There is one question from Dr. Upinder Kaur. I will take that question, and then after that, final comment from Honorable Director, sir. So, Dr. Upinder, over to you. You can ask your question rapid within 10 to 20 seconds. Dr. Upinder, you can unmute yourself.
Yes, sir. Sir, you can directly ask the question from the chat box.
Okay.
Okay, sir.
I think in the chat box you asked about presenting unit should mention the response to therapy. Mentioning diagnosis without response is equally puzzling. Okay, I think that's the feedback that can be taken. So I request Honorable Director, sir. Sir, final comments from your side. Over to you, sir.
Thank you, Abhishek. Today, both the cases, interesting cases, and both were movement disorder cases. Well presented by neurology department and well discussed. Similar case from psychiatry, well discussed. Though debate was going on regarding the treatment, all this will continue. You can continue. Not much comments, but good presentations. Thank you.
So thank you, sir. Thank you everyone for joining this clinical society meeting, and see you at the next meeting. I close this meeting now.